Hello everyone, my name's Angelika Sharma. I'm an academic clinical fellow in endocrinology and internal medicine training in the east of England. Thank you so much for attending this joint event with the Society of Endocrinology and the Young Diabetologists and Endocrinologists Forum. So every year, the Society of Endocrinology hosts these webinar sessions with the aim to inspire and inform the next generation of endocrine specialists. The first of this two-part series took place yesterday, and today the focus will be all on diabetes. We're lucky enough to be joined by a panel of specialists in the field, all with stellar achievements both clinically and academically. They'll be discussing and sharing their top tips with you. So just a few bits of housekeeping. The webinar is recorded, so if you could kindly turn off your mics and webcams. During this session, feel free to ask any questions using the chat function. So there'll be a dedicated question and answer session at the end. And at that point, you'll also be able to raise your hands and ask any questions live. So without much further ado, I'd like to introduce the first speaker. So this is Dr. Raj Palani. He's a specialist registrar in diabetes and endocrinology. He's an SD5 working in the North Central London Deanery. In this session, he'll be sharing his experiences on navigating the application and the interview process, as well as being an international medical graduate. So if I could ask Dr. Raj to please take it away.
Hi, everyone, and thank you for the introduction, Angelina. So let me share my presentation. Yeah, I hope everyone can see my presentation now. So I'm Dr. Palani, SD5 in North Central London Deanery in diabetes and endocrinology, and the topic that I'm going to talk about is about navigating the application and interview process. And I'm going to give the perspective of an international medical graduate. So this talk is directed towards SHOs, IMTs, trust-grade doctors who are pursuing or thinking of pursuing a career in endocrinology and diabetes. So hopefully this talk will help clear some doubts about the application process. Now, the two most important websites that I need everyone to know about for the application process. The first one is Oriel. Oriel is the website where you actually go and apply for a specialty training number. And the other one is phstrecruitment.org.uk. So any questions, any doubt you have regarding the application or the interview process, you can get that information from this website. The reason why I mentioned these two basic websites is because being an international medical graduate, the whole process of getting into a specialist training was quite new. All of these websites were new to me, and it took me some time to get adjusted or to get to know all of these websites in detail. So I would suggest before you apply, go through this website, especially Oriel, create an account, log in, and just go navigate the website, both websites. Yeah. Now, when you're considering a specialist trainee registrar number in diabetes and endocrinology, the first question that you need to ask yourself is whether you're eligible. So I would think about this about a year before applying for my ST4 in diabetes and endocrinology. Now, this is a group 1 specialty, meaning that you should have either done 3 years of IMT training or an equivalent. And when it says equivalent, it's basically asking you to have an alternate certificate of competency. Again, this can be found from the document library from the PHSC recruitment website. So you go there, there's a document library. Inside that tab, you can find this alternate certificate of competency. You download that. It's about 7 or 8 pages. It's quite extensive. It tells you all the competencies that you need to get signed off from your education supervisor or your consultant. And once you have signed that off, that means you are now eligible. The other eligibility, obviously, you need to have MRCP UK. You can apply for a specialist training with just passing the first part of MRCP. But to become appointable, when the offers are made, you need to have the full MRCP. Let's say you become appointable, you get an offer into a specialist training, but you have not completed your MRCP. In that case, the offer would be withdrawn. So my advice would be to get this MRCP off before applying. And then obviously you need to have the GMC. Now, planning, there will be 2 rounds every year. So round 1, which happens in August, that intake would be in August, and round 2 for intakes in January and February. Not every year you will have some vacant positions in round 2. So it's important that you keep that in mind, because sometimes there will be 0 seats available in round 2. And again, like I mentioned before, you need to go to the Oriel website to make an actual application to get into the training. So Oriel is a UK-wide portal for recruitment to postgraduate medical training. So, create an account, navigate through, and then that you will get an idea of how this website works. Now, coming to the actual application form, which is divided into 4 main sections. The first part is easy bit. It's your personal information, equality and diversity, your employment history, which is fine. The second part, you have your training history, previous training details, references. So these references means you have to get references from your consultants, and it's always better to inform your consultant that you're putting their name down as references for specialty training application so that they can respond to emails that may be sent to them later on once you have been offered a position. And then fitness to practice declaration and competence and eligibility. This is where it will give you a section to upload your alternate certificate of competence if you have not done your IMT 3 years of IMT training in the UK, meaning that you have come as a junior doctor, you're working as an SHO in a trust, but you do think that you have the necessary competence and experience to get into an ST4 level, then you need to get that certificate signed off by your education supervisor and then upload it onto this section. And the third part is evidence, supporting documents, and self-assessment. So this is important. So I'll talk more about these 3 bits in the next few slides. So starting off with self-assessment. So self-assessment and application scoring. So you score yourself based on all of these areas of assessment, and then you give yourself marks for each and individual of them. So for example, the areas of assessment that are assessed are like if you have had a postgraduate degree and qualification, you can assess yourself and give yourself some score for that. Any additional achievements, for example, if you have had any grants, if you have had any awards, you can put that here. CPUK obviously carries its marks. Posters and presentations, again, if you have presented any poster in a national or international conference, you can mark yourself for that. Similarly, publication, teaching, quality improvement or audits, leadership, and commitment to specialty. Now for international or for all applications we're applying, I think some of the easy bits here would be like presentations, or getting a poster presentation or an oral presentation in a national conference, which is fairly easy to get some good points. Public teaching is fairly achievable. You can create a own teaching schedule for medical students. So whichever hospital you're working at, you can make a schedule for 4th year or final year medical students, and you can pick one topic from diabetes or endocrinology and you can do this teaching and you can get some points for that. Audits also, you can design some audits if you're working in acute medical unit. Again, that carries good points. So coming to the next slide, I've just given you an example of scoring for presentation. So let's say you've done an oral presentation in which you were the first author and you presented this at regional medical meeting, and then you can score yourself 5 points for this. Again, all this information are present in the website that I mentioned before, PHST recruitment website. So you mark yourself based on what mark that you're supposed to give yourself. Let's say you've done an oral presentation in a regional meeting, you can put yourself down as 5 marks. If you've done it as a national or international, you can put yourself down at 7 marks for that. Now, all the marks that you are putting yourself, so you're doing the self-assessment and you should provide evidence for that. So let's say you have presented at a regional meeting presentation, you need to upload the certificate for that. And that certificate would be reassessed by an assessor, and then he will make sure that the marks that you have given yourself are actually correct. Let's say in an instance, you have marked yourself as 7, however, you presented in a regional conference, so that will be picked up by the external assessor, and then you will be sent an email telling that your self-assessment scoring mark has been reduced from 7 to 5 in this particular domain because the assessor felt that the presentation was not done in a national conference but rather a regional conference. So you just need to keep that in mind. So you need to be true to yourself when you're doing self-assessment, because these will be checked at a later time. And then you would have noticed that there is a section called commitment to specialty. So this is actually important because this carries about 30% marks of your initial application process. 30%, just this commitment to specialty. So essentially, you need to be quite thorough and you need to put a lot of information on this, detailing your commitment to this specialty, what you have done for this specialty, why are you interested in this specialty, your audits, your any research, your anything that you have done remotely for this particular specialty, you need to include that in this. So the marking for this would be either 10. So there'll be 2 assessors, so 10 and 10 each. So 10 and 10, or 2 and 2, or 0 and 0. So you need to make sure you get 10 and 10. And if you get 10 and 10, that is 30% of your application scoring. So that's a good solid mark there. And this would only be used for shortlisting. This would not be used for the ultimate appointability or for offering positions. Now, so that's the self-assessment and scoring bit. So now after submission, so let's say you've gone through all of this, you've done your application process, you've finished all of these things, you've done your self-assessment, you've uploaded the evidence, and now coming after the submission, there is long listing. Essentially, the first slide that I said, are you eligible? If you are eligible, you will be longlisted. If you're not eligible, you'll not be longlisted. And then shortlisting. For shortlisting, they will go back to your self-assessment evidence. They will give you points, score you, and then they will tell you you have been shortlisted and your mark is so and so scoring that the team has given you. So, and then based on that scoring, you would be called for interview. Now, interview again can be quite, when I first attended interview, it's quite extensive, and where to get the information, what information to, or what to expect during interviews. So essentially, there are 4 stations, and the 5th station is communication skills, which will be assessed on these 4 stations. So there's no separate communication skills station. The way you communicate in all these 4 stations, that is how it is taken. So the first station would be clinical scenario endocrinology, and station 2 would be medical registrar suitability. Now, the thing to remember in clinical scenario endocrinology is this is a clinical scenario. So you need to prepare for common endocrine conditions like acromegaly, Cushing's, primary hyperparathyroidism, etc. The question 2, medical registrar suitability, you need to remember they would not ask you questions about acute medical emergency, but rather non-medical questions like management skills, leadership skills, acute unselected take. So things like that. And always when you're answering these questions, you need to come up with an example that you may have personally witnessed or experienced. So whenever you're answering these questions, you have to give an example. Like you say, well, this has actually happened to me and this is what I did, and that is why I feel that I have good leadership skills, so etc., like that. And similarly for diabetes, you have a clinical scenario, and then you can see there's another suitability and commitment station here. So this is why first suitability mark that you have self-assessed yourself, that would be checked off here, and there's a separate station. So what they need you to do here is they will ask you to give a 3-minute presentation that why you think you're interested in this specialty, why you feel that you are the ideal candidate, and what you have done to make sure that you get into this specialty. That's 3-minute presentation. And then after that, there will be a 7 minutes of question and answer. The usual question that's being asked like, where do you see yourself in 5 years? Which subspecialty you want to do? Why did you choose endocrinology and diabetes, and things like that. And then, like I said, the communication station is just like is the way how you perform all these 4 stations. Now, how they mark you in interview, the markings, there will be 2 consultants for these 2 stations, clinical endocrinology and medical registrar suitability, and two other consultants for diabetes clinical scenario and suitability and commitment. So there are total 4 interview panel, and they will mark you down as 1, 2, and 5, 1 being poor, 5 being excellent. Again, all of this information is available in the PHST website. So once the interview is done, how the appointability offers when they come out. So you need to make sure your raw interview score must be 30 or above to qualify. And none of your 10 interview scores can be 1 out of 5. So remember this. So none of it should be 1. And again, not more than 2 should be 2 out of 10. So if you score 1 out of 5 or in more than 2 stations, 2 out of 5, then you're automatically disqualified and will not be appointable. So once you have cleared your interview, then you become appointable. You will be given a national rank, and based on that rank, you would be given a appointability and an offer. Now, this is the total score. So one thing that I need, there's a small trick. One thing I need everyone to remember is that the clinical scenario in endocrinology, although the interviewer 1 is scoring you out of 5, the weightage is 2.5, meaning whatever you score here, it's 2.5 times of that score you get as your maximum score. Similarly, if you see a medical registrar suitability, it's just the same. So you should give more weightage and more importance to clinical scenario endocrinology, clinical scenario diabetes, and suitability and commitment, which is 1.8 times your actual score. And then the maximum, and then all these scores are added up out of 90. They will give you a point. Now, the application score that you did earlier, the self-assessment, that is also included in this one. So it's important that you have a very good application score so that it boosts up your chance of getting a training number in endocrinology and diabetes. But only 40% of your score would be included here. And again, this would not include your commitment to specialty, which you self-entered in the beginning. So excluding that, you will get 40% of whatever score you have that, and then the total score comes down here. Right. So I think it's important that you know how the scoring is done so that you can concentrate more on the aspects that can fetch you more points. So like I said, once the interviews are done, based on your points, offers will be made. You have to also, if you're region bound, you have to give preference to your regions, and then the offers would be made according to your points that you have scored, and depending on your post preference or region preference. So that's all about the application process. Some take-home messages. Now I'm delivering this talk keeping in mind international medical graduates, so it could be quite difficult, the whole process. So the first thing first, go through those two websites, ORIEL and PHST recruitment. Start planning for your application at least a year in advance, because you need to gather all evidence for scoring, like poster presentation, you need to do oral presentation, audits, QIPs, teaching program, which should be at least 3 months, things like that. And so ensure you work towards evidences that have maximum scoring. So like if you do a poster presentation at a national conference, you get good marks. So things like that are not too difficult to do, not taking too much time, but are fetching you too much marks, things like that. And then remember about the commitment to specialty. MAC carries about 30% of scoring for shortlisting. So make sure you are quite extensive when you explain about your commitment to specialty. And if you've not done your IMT, again, for alternate certificate of competency, give at least 1 year time. And one of the requirements now for alternate certificate of competency is that you should have worked in elderly medicine department and intensive care department for a minimum period of 4 months. So make sure, if you have not worked in this department, make sure, approach your rota coordinator and make sure that you do these rotations, so that there's no issues at the end. So again, give it at least a year. And it also tells that you have to take 500 acute medical patients. So keep a logbook of all the acute patients that you see, so that when you go to your consultant to get your alternate certificate signed off, there is no issues and you have all the evidences. And for the interview, bear the weightage of differentiation in your mind. So like clinical scenario for endocrinology and diabetes, bear the maximum weightage. So give more importance to them. Practice mock interview with your consultant or your senior registrar and ask for feedback. This is something I cannot stress enough. This is very important. Do mock interviews. If you're not able to find a consultant, go to a endocrinology and diabetes senior registrar and just say that you want to practice some mock interviews, and then get feedback. Go through because the endocrinology and diabetes scenarios are the most weighted stations, go through some common scenarios. And the competition lately in diabetes and endocrinology, the competition ratio has gone up quite significantly after the pandemic. I think presently it's around 4.5:1. So just getting to a diagnostic might not be enough because of so much competition. So for example, I have highlighted primary hyperparathyroidism here. So let's say you get a young patient with primary hyperparathyroidism. Go a bit further, try to think of this as a endocrinopathy syndrome, maybe MEN1. Maybe because this is a young patient, maybe you want to do some genetic testing. So go a bit beyond than usual. Yeah. So keep that in mind. And the other thing is, in terms of diabetes, go through the new guidelines in type 1 diabetes, new technology, the new medications. And something in diabetes station that many candidates might not explore is the socioeconomic issues that these patients with diabetes have. So make sure you discuss those issues in your station. And clinical scenario, if you are not able to come to a diagnosis, always ask for some additional information. Don't shy away not asking that information. Come up with a diagnosis, differential, investigation. I have bolded DFT here because you want to do endocrinology, in diagnosis, try to attach a dynamic function test with that diagnosis. Yeah, that might impress the interview panel. Management, MDT discussion, because endocrinology conditions are quite rare. And then always ask for genetic testing if it's a young patient. Sorry about the cough. I'm just recovering from a flu, so my voice is not back yet. So for medical registrar suitability, remember, they would not ask you any acute medical cases. They will ask you non-clinical aspect of being a medical registrar. Specifically, this is mentioned in the PHST website, managing an acute unselected take, managing a multidisciplinary team with effective discharge planning. So you need not study about all the management of acute emergency conditions, but rather managing an unselected take or interpersonal skills. And please come up with an example when you're doing this station. So I think that's all for my presentation. Hope this was helpful. Thank you for having me.
Thank you so much, Dr. Plani. I think it's really helpful to be thinking about keeping up with the different domains of the portfolio early on, and importantly, collating all the evidence for the application process. Just a few bits of housekeeping. I know some of you joined us a bit later on. Please use the chat function to ask us any questions. We'll have a dedicated Q&A session at the end with the panel. So onto our next speaker. So I'd like to introduce Dr. Lauren Quinn. So she's currently a clinical research fellow specialising in the immunoprevention of type 1 diabetes, and she'll be discussing career pathways and a bit of a day in the life of a clinical academic in endocrinology. So over to you. Dr. Quinn.
Thank you, Angelica. I'll just share my slides. Great, I hope you can see those okay. So thank you so much for the introduction, and thank you for the opportunity to speak this afternoon. So yes, so my name's Lauren. I'm an academic clinical fellow in diabetes and endocrinology, and I'm currently undertaking a full-time PhD at the University of Birmingham, focusing on the ELSA study. So through my talk, I'm going to talk to you a little bit about the diabetes landscape that is relevant for all diabetes healthcare professionals, present and in the future. I'll then go on to talk about my academic interest and the future of type 1 diabetes, regarding perhaps screening and maybe even immunoprevention. And finally, I'll touch on yourselves and pursuing an academic career and kind of resources you could look into if this is something of interest. Okay, so firstly, the current diabetes landscape. So this very complicated mind map shows you everything that applies to somebody living with diabetes. This is relevant whether it's type 1, type 2, or another form of diabetes. So for the individual, there's often frequent capillary blood glucose monitoring. They may be taking regular medications and or insulin injections, particularly if they're type 1, carbohydrate counting with every meal, healthy diet and lifestyle, risk of hypo and hyperglycemia, diabetes-related complications, mental health implications of diabetes, stigma they may face from the general public. It's a very long list. So you can imagine in any consultation with a person with diabetes, in that 10 to 20 minutes, there's an awful lot to cover. And it just shows the challenges that diabetes presents to the individual patient. Now, I think if we look at diabetes management, particularly over the last sort of 20 years, where we have diabetes registries internationally, we are off target. So our patients with diabetes are not meeting optimal HbA1c targets. And the problem with that is the risk of micro and macrovascular complications. And we know that people with diabetes already have a heightened cardiovascular risk, even if they are well controlled. So we are just adding to their risk of future health problems. And this has implications on their lifespan as well. So this is significant. And this graph here, this is actually paediatric audit data from the UK, from England and Wales, and it shows you data from 2009 up to 2020, and we can see the average HbA1c levels for the children as a population. Back in 2009, the median was 72 millimole per mole. More recently, we have improved this down to about 62 millimoles per mole, which is a significant improvement, and that's been through auditing, registries, improved structured education, improved access to technology, but we're still not meeting targets. And for adult patients with diabetes, we should be aiming for less than 48 millimoles per mole. So if our average is 62, we are way off target. But I hope this is a reflection of the past, and I'm going to talk to you about what improvements are being implemented to try and change this. So diabetes past, so 100 years ago, just over that, insulin was discovered. Prior to that, patients might have undertaken calorific restriction to try and prolong their lifespan. But realistically, if you had type 1 diabetes, you would live for a matter of months to years without insulin. So when insulin was discovered, the patent for insulin was sold for $1 to make it a widely accessible medication for anyone that needed it. And insulin has been the mainstay of treatment for type 1 since this day. Interestingly, technology is a more recent phenomenon. So, for example, in the 90s, this is when perhaps the insulin pumps and the glucose centers started to emerge in the research space. But this technology has only come into clinical practice really in the last 20 years. And we've seen phenomenal changes. You know, every year we see changes in diabetes technology. So it's a really exciting specialty to be a part of, and a real privilege. And this diagram just shows you the wealth of technology our patients now have access to. So we're talking about glucose sensors, insulin pumps, so continuous infusion of insulin, and then apps and algorithms to help support diabetes management and try and decrease the burden. So there's a lot of choice. This obviously adds complexity to the management of diabetes, but it actually makes the day-to-day life easier for the individual patient. And we are seeing improvements as a result of technology and making, for example, glucose sensors widely accessible, so available for all people living with type 1 in the UK. As a result of this, we are now seeing HbA1c HbA1c improvements. So this graph shows you, for example, across the different years, comparing 2017 to 2021, and we can see the proportion of patients with a HbA1c less than 58 is thankfully increasing over time, whereas the number of patients with more poorly controlled and higher HbA1cs is starting to decline. So great, we are seeing improvement. So glucose sensing is certainly one improvement, but perhaps the future of type 1 diabetes will be hybrid closed loop systems. So this is where the glucose sensor speaks to the insulin pump via an algorithm. So usually either via a device or a mobile app. And this means that there's automated insulin release. So the patient with diabetes has to bolus and carbohydrate count, but otherwise that there is slack in the system. So it will give you insulin if needed, and it will pause insulin if you're dropping low. So this is really exciting. And you can see here, we are expecting nice guidance to come out later this year that will allow all patients with a HbA1c of 64 millimole or above to have access to hybrid closed loop systems. This is revolutionary. And it's revolutionary because this is what really makes a difference to patients' lives, to their HbA1c. It reduces diabetes-related distress, and it improves quality of life as well. So this is really reducing the burden of diabetes. And for everyone in the audience today, if you go into diabetes as your specialty, you will be seeing these patients coming through with this incredible technology. So as professionals, we do have to familiarize ourselves with a lot of data very quickly in every consultation with patients, but it's just fascinating, you know, how much improvements we're seeing all the time. So I'll move on very quickly, if I may now, onto my area of academic interest, which is all about the future sort of diagnosis, management, and perhaps even immunoprevention of type 1 diabetes. So this news article, this is the first immunopreventative treatment to be licensed for individuals at risk of type 1 diabetes. So I said at risk there. So what does this mean? How are we identifying individuals at risk of type 1? Because in our day-to-day practice, we diagnose type 1 after a run of symptoms. The majority, many are in diabetic ketoacidosis, not the majority, sorry, about 1 in 4. So that's our classical clinical presentation of type 1 diabetes. But actually, this is a condition we can screen for. And we screen by looking at islet-specific autoantibodies. These autoantibodies actually predate clinical onset of type 1 by 10 to 15 years. So we have a window of opportunity there where individuals are asymptomatic, but they have these antibodies lingering, waiting to cause beta cell depletion and damage, and then leading to ultimately clinical type 1. So when we screen, we're screening for antibodies to try and identify individuals at earlier stages of the disease, so either stage 1 or stage 2. So this is screening, and actually we have a big study in the UK called the ELSA study, which is currently offering screening to children aged 3 to 13 years. And then we inform the family if the child has autoantibodies, and then we can then counsel the family and offer follow-up to track that child's progression over time. And that's one of the major benefits of screening and identifying pre-symptomatic type 1. We can offer follow-up through other research studies, so we can track that child's progression towards type 1, and that means we can avoid that morbid phase. So that's a phase where children become really unwell, lose a lot of weight, are thirsty, pass a lot of urine, and as I say, 1 in 4 in diabetic ketoacidosis. You can completely avoid that by screening and monitoring, because you're tracking the glucose much more closely, and as soon as insulin is needed, you get it started. So you've transformed the diagnosis for that individual and for their family. So that there's I suppose a clinical benefit there and a psychological benefit. But there's also then access to immunopreventative treatment. So for example, teplizumab, which was the first immunoprevention to be licensed in the US, we are waiting on a licensing decision in the UK and Europe. We're hoping a decision will be announced next year, and it's going through a nice consultation process at the moment. But this is a treatment that can delay the need for insulin by 3 years on average. Some a little much longer than that, others a bit shorter, of course, but on average 3 years. So 3 years without needing insulin, without that glucose monitoring. It might sound like a really short period of time, but actually patients tell us that that really matters, that 3 years. And this is the first. There will be other trials coming through that are adding to teplizumab, for example, to try and delay that start of type 1 diabetes even further. So a really exciting field. This is currently applicable, screening is applicable in a pediatric setting. We don't screen adults because there's more complexity, there's a bit more, obviously a lot more type 2, and there may be incidental antibodies, so we don't quite know what it means as much. However, teplizumab, this immunopreventative treatment, has been licensed to individuals aged 8 years and above. So there will be adults, perhaps knowing they are at risk of type 1, either genetic risk or family history, that are going to be interested in this treatment if it were to be licensed. So screening for type 1 in adults is another debate, but it's something we're interested to look more into to understand the natural history. Okay, so thinking about my role in the ELSA study, so undertaking a clinical research fellowship and undertaking my PhD, and these are all the work packages that I've been involved in. I'm just about to enter my 3rd year, and some of this work was part of my academic fellowship as well. So it's a lot of pieces of work that are coming together, and I hope will continue beyond my PhD. But firstly, it was about speaking to patients, parents, and stakeholders about what they wanted from a screening program. So this kind of co-design and patient and public involvement. And this was impactful because it changed the design of the ELSA study. And this work has gone on to be published in peer-reviewed journals. And there was then the screening test. So how on earth do we screen people for autoantibodies? So this is we validated a dry blood spot, which is a finger prick onto a blood spot card. It can be done at home or in the community, posted back to us, we analyse it in the lab, and then we return the result to the family. So it's a quick, cheap, easy, very low failure rate screening test, which is exactly what you want. And this is what we've implemented into ELSA. There's then the feasibility of screening, and that's a big part of my PhD, is how do you recruit, how do you roll out screening in the UK? And we're doing this through a trial. And then finally, the acceptability of screening. And that's the big piece, is it acceptable for families to go through a screening programme? What is the impact of finding out their child is at risk of type 1? And there will be a psychological impact to that, because you're almost bringing the diagnosis earlier on in the process. So what support do families need to support coping and adjustment? And that's really been the biggest part of my PhD, mixed methods, but a significant amount of qualitative work. And as a result of that, this is kind of the mind map we've developed. So this is the support that families need when they've been through screening. So for example, they would benefit from one-to-one education about signs and symptoms of type 1 and about what the screening results mean. We notify the child's GP. So if that child does develop symptoms, they're going to test that child for type 1 if there's any seed of doubt. We signpost the family to other research studies, so immunopreventative trials. We let the families know about this immunopreventative treatment in the US that we're waiting on a decision on, and let them know if it does become available in the UK, as ELSA families will let you know where it's available. And then also, of course, the follow-up and any psychology support. So very quick, whistle-stop tour of ELSA and my PhD, which has been an incredible experience to really feel like you're making a difference to something. You know, we're trying to imagine what a future screening program might look like in the UK. And this is relevant because there's screening programs all around the world, and Italy is actually mandated paediatric screening for all children. So if Italy have a mandate, then you can see the importance of this and you know where it's heading. We don't know how far away a screening program in the UK will be, but we certainly hope ELSA as a research trial will continue for the foreseeable future. And then just one more minute just to end on is about clinical academic careers in the UK. So we're very privileged that we have this academic training pathway. So if you're interested in research or a particular subspecialty, you can have research time alongside your clinical training to support your research career, whether that's in the foundation programme, as an academic clinical fellowship, or beyond your higher degree, then going into clinical lectureship. So there's all these opportunities to undertake research and I think really make a difference on an international scale, and that's what I think one of the most rewarding things of academic careers. So if you're perhaps wondering, or maybe I've inspired you to think about an academic career at least, where should you start? So I've provided some links here. I'm of a West Midlands trainee, so I've had so much support from the West Midlands Deanery and from my academic tutors, so that's a really good place to start. There's Health Education England and also the National Institute for Health Research, who lead on that academic career pathway for fellows and foundation doctors. So 2 really good resources there. And then mentors and colleagues, so speak to people. That's what academia is all about, is networking. And then finally, the YDEF, so the Young Diabetes and Endocrinologists Forum. I strongly recommend that you join their newsletter bulletin. They have loads of courses, prizes, opportunities, conference funding opportunities. Everything is in the newsletter, and you can also have a look at our website. So definitely a good start, and you don't have to be a specialty registrar to join the YDF. We're looking for early career trainees as well. So a huge thank you to my team, who my professional and personal support network throughout the PhD. A special thank you to my supervisor, Professor Partha Ren, and my co-supervisors, Professor Alex Richter and Professor Sheila Greenfield. So my final question is, why would you not do diabetes? Thank you for listening, and happy to take any questions.
Thank you so much, Dr. Quinn. So really interesting to see the positive trajectory of managing patients with type 1 diabetes, and especially increasing access to the hybrid closed loop systems and the new methods for prevention using screening. So our next speaker is someone who actually inspired me to go into academic clinical endocrinology when I met him a few years ago. So that's Dr. Amar Patana. He's a diabetes and endocrinology consultant currently in the West Midlands. He has won numerous teaching awards, patient care awards, you name it, he's probably won it. He currently sits on the board for the MRCP examinations, and he's also involved in writing the guidelines for the National Joint British Diabetes Societies. He's going to be sharing a bit on his career pathway and how he's managed to link working in industry along with clinical practice. So thank you so much, Dr. Patana.
Thanks, Angelica, and hi everyone. Thanks. I didn't realise I inspired. I'm one of the reasons. I appreciate that. It's amazing how things come full circle. I remember when I was with YDF myself, starting to coordinate these careers, insights, and careers day basically, and it's nice to see it grow and see everyone interested still. So yeah, it's been really fun to kind of see everyone here and to hear the talks as well. I'm just going to share my screen. That should hopefully work. Yeah. So yeah, I guess my career has been quite varied. I've done a fair bit in a short space of time. I'm 5 years into being a consultant now. And I thought, well, the best way to kind of talk to you about kind of being a consultant and what that involves is probably kind of take you through what I did and what happened in my career, give you some insights into the possibilities for yourself, either as students, as trainees, as juniors, whatever you want to call it, to kind of see what the possibilities are, what you might want to consider, but also some things that can happen in the career as a consultant. It's not all just clinical. I was fortunate enough to have opportunities, and as I took advantage of them as a registrar, what many people would do as a consultant. So I've kind of, what I've done and what I've shown you is kind of things that you would do as a consultant, but I've sometimes done, some people can do a bit earlier. So first thing to really kind of say is essentially, is that enough? I'm a consultant. What more? That's the whole point, isn't it? In med school, you kind of go through, you can't start training, and you want the end point to be a specialist in whatever subject you choose, which is endocrinology, isn't it? And diabetes. And should there be any consideration beyond that? What, isn't it fine just to reach that level of what you wanted? And yeah, I think that's something you've got to ask yourself really down the line is are you happy? It depends, really. What are you interested in? What are the considerations for yourself? You become a consultant in your 30s, early 30s, and you've got 35 years of it or so. What you want to be doing in that, and that's going to change over time. I mean, you don't have to think all about that right now when you're in the early stages, but when you get to be a consultant or on the training side, you have to consider that. Is it education? Are you interested in education talks? Is that local education? Is that medical student education? Is that international, national, in between kind of education? Is that patient education? Research, again, but I have interest in research and I've been fortunate to get involved in some, but I'm not a true academic researcher, unlike some people on this talk and this call. But that's something, again, that if that interests you. The management and more how you run things, how you run the hospital, how you run your services. Are you interested in change? And by change, I mean changing structure, changing care, changing pathways. And that could be in the hospital locally, could be regionally, and it could be nationally or internationally even. Again, it depends on your ambitions, and this changes over time. It's not just what you think at the moment, but it's something to be to consider what interests you, what might consider interesting you when you are a consultant. Guidelines and policy. Do you just want to review research and try and put research into practice and try and implement things for the benefit of your patients? Do you want to work in a hospital, or as a consultant, you can work in community care as well and primary care. That's some of the benefits of our specialty as well. You get to work across the spectrum of healthcare, which is perhaps not as unique as it once was, but it is still embedded almost in a lot of what we do. And of course, there's non-medical work as well. You can do other things such as be involved in from a legal perspective in different things. You can get involved in other areas which we'll talk about potentially as this talk goes on. So I thought I'd really talk to you a bit about my career, or as I say, my story, essentially. I think it's more of a story of kind of what's happened and what I've done, just to give you an idea of things. So I was quite fortunate in a way. I knew third year I did a special study kind of module in thyroid disease at the University of Birmingham. And I kind of had an idea that I was quite fascinated by that endocrine side of things, and the fact that it was so wide reaching. One condition, one area can affect the body in so much ways, and the management was quite, it would have massive impact on people. So that quite fascinated me. I guess that's where I started. And then fourth year was where I really kind of, the elective when I went on fourth year was the Mayo Clinic, and it was again looking at thyroid disease as well, and it was very it opened my eyes and thought, this is definitely what I want to do. And many people won't have that. Many people will still kind of go through. You don't have to have know what you want to do as such. Obviously you're interested because you're on this webinar, but some people don't know until kind of further down the line. But I was just fortunate that I knew at that point. The medical school was pretty much kind of, as with most people, it was it wasn't that. Sorry, ignore that. No, it wasn't that either. There we go. That's what it was. It was about learning and understanding about medicine and certainly endocrinology. And so foundation year 1 and 2, I actually didn't do any diabetes and endocrine rotations at all, and didn't have publications. I think I had one case report, that was it. And that was kind of as a medical student, I failed and I managed to get that. But what I did do was become a student member of the Society for Endocrinology. I still remember that being recommended, and that was key for me. Kind of it opened my eyes to a few things and opportunities as well. As a core medical trainee at the time, it's now IMT. I further developed my interests but again, I did one rotation in diabetes and endocrinology, so 4 months, and attended a conference which was Diabetes UK. And again, that further opened my eyes, and it was a student. It was you get subsidized attendance because you're not a specialist. At the time, YDEF didn't have a junior membership, so I hadn't joined them then. But it's when I got into the training where I really took every opportunity. Essentially, I had posters, publications, presentations, joined YDEF, became chair of YDEF, joined the RCP as an exam board as a trainee, joined the Royal College as a chief registrar, which is kind of a new thing they're developing to try and get registrars into more management experience. And as a fortunate of some of the quality improvement projects and audits I did and some of the work I'd done, got some awards, which was mentioned earlier. So again, I really maximize that. I'm happy to talk about that if you want to down the line, but I think it's just something to give you an idea of the things that you could do and where to show you that actually where you are now, it takes time. And actually the fact that a lot of the stuff I've done was really in that training time. So don't feel that things have to be done so soon. This was my week as a registrar. So again, it was 2 different hospitals. One was quite nice. It was very diabetes focused, to give you an idea. So it was blood sugar, diabetes management on the inpatients, clinic, admin or clinic, rounds and clinic. It was quite nice. And this place didn't have a ward at the time, so it was quite nice. It was just pure diabetes and endocrine. Whereas this is a more traditional job, which was the bottom, which was ward rounds in the morning, essentially, except for a few clinics in the mornings, and then clinics and time and one admin session in the afternoon. So again, this is kind of to give you an idea of some of the possibilities as a registrar which I had. On-calls and days off were limited to the above, of course, but generally I had a very good training in the West Midlands. It was very receptive to what I wanted and what I needed and what I chose. I kind of shaped it, which was quite nice, and I had a supportive team. As a consultant, again, the top one was in that same hospital, which when I started there, I was a consultant there for a bit and then moved. So that's again very similar, quite a nice. I had specialized Wednesdays, which were for pure audit, because it was part of a national. It was a national society that paid for it, kind of to cover that. So I did audit work in that time, which was a bit of research, and the rest was, as you see. More recently, last few years, up until 2022, I was doing this, which was ward rounds in the morning, essentially, in a DGH, and then clinic and admin in between. So again, it was a bit more traditional, where you cover the wards and see your general medical patients and do your specialty at different times. And I was good with that. This is fine. This worked nicely for me. Either ones. I preferred obviously the top one because it gives me time and more research side of things. But again, things change at time and you do different things. So that was kind of where I started as a consultant. And what I did really as a consultant and as senior registrar, essentially, it was more than just clinical. This is why I say just clinical, because, I love clinical medicine and seeing patients and managing, treating, and gen med and diabetes and endocrine is something that I enjoy, so I wouldn't change that. So started off really at policy changing, changing care locally and being part of a medicines management group in the hospital in the West Midlands, where we looked at medications and tried to make sure people had access to medications, provided guidelines for the local primary care teams. Continue my education both in the hospital, teaching not just our trainees and medical students, but also other specialties as well, giving talks, and education nationally and internationally as well. Developing consensus statements and publications, presentations, still continuing that both in primary and secondary care. I developed a specialist interest in a couple of areas. One was older adults with diabetes, one of my key areas of interest, dementia. Did a lot of work in that field, and older adults you'll see in a second. Did a lot of work in education on cardiovascular disease, and now developed that over to oral health and reviewing research and really kind of critically appraising things. So I did develop my knowledge that side, and as a result of that, you get more and more awareness. People are more aware of you, and you get more opportunities in the national and international level. So that's why I say more than just clinical, because it's all right to look in one area, and you're perfectly fine seeing your patients and doing that if that's what you're happy with. But for me, I knew this is what I wanted to do, a bit more kind of far-reaching things and meet people and interact with people and people such as on this call. And these are some things that I did. So again, work with the JBDS, create the inpatient care of the frail older adults with diabetes. Local guidelines I mentioned in BSO are still present, and guidelines for choice of oral agents and diabetes. Fortunate enough, again, as a trainee, really, to get an RCP award for excellence in patient care, which is one of the highlights of my career, actually. Again, diabetes and frailty and expert consensus, which is used quite a lot and referenced a fair few times. So again, really proud of that. It's very blurry because this is my first RCP Edinburgh teaching award a long time ago. I'm glad it's blurred. You can't see my youthful face. And then again, this other important thing, I won a quality and care award for this dementia project again. So it just shows that things you do as a registrar and training, this quality improvement project, it had far-reaching effects and still benefit from it to this day. And it's really just to highlight that. But again, one of the other things I guess was actually having a PubMed citation with my name on it, which is nice. As in, you can search for my name on PubMed and you can get this, which is careers discussion with the BMJ, which is quite nice. Ignore the cheesy photo. And so things were working quite nicely for myself, obviously post-pandemic, all the side of that is, that side of things you all dealt with. But I got the opportunity in early 22 really to join a pharmaceutical company, which again, just to make it clear, talk I'm giving you today is purely as me as a clinician, nothing at all to do with that. I'm giving you just my story essentially. And there's a lot of things made about industry. And when I still think about it, it's kind of, you hear this thing called bad pharma. Oh, you're there for the pharmaceutical industry. Oh, when people talk, you've seen a lot of the kind of I guess a lot of things on in press, but also in Netflix and things like that. And so I think for me, I had interactions with the pharmaceutical industry throughout, because when you're part of a guideline committee, when you're part of people looking at, you have to understand a bit more about the medications. When you're prescribing medications, you have to know a bit more about it. So I was working with them, and again, for my education background, again, it was I had good interactions with them, so I was aware of them, and so for me, I had to really answer a question: why would I do something like that from my perspective? Why would I join the pharmaceutical industry? What's the benefit to me? And so this is some of the things that I thought about. Well, actually, for me, I mean, not everyone gets this opportunity is the key thing. And I think it was a good opportunity to have. And I thought, well, it's something different, something that I haven't experienced, something that I haven't got but much knowledge on, how things work, understanding if I really want to see, I guess, how medications are developed or brought into a country, or how things work from that side, it will help me as a clinician, help me to understand a bit more. So for me, it was an opportunity that I found quite fascinating and a learning experience, is that honest answer, a chance to educate myself on this side of things. The timing worked relatively nicely as well. So again, in life, you'll find a lot of it is timing, and it seemed to match with myself. Again, the interest I mentioned about that, to see things from a different perspective, look at a bigger population care. So I was doing stuff on a national and regional level, but actually want to look at it in a kind of bigger level and see how can have more impact, bigger change. And I think that's the key thing for me. That was kind of following the discussions, it made sense to me, and to provide my experience and my knowledge as a clinician and as a specialist, and being interested and fascinated about diabetes, to really provide that opportunity and learn as well. And so that's the thing I mentioned, future planning. It's about look at the future and looking at, you know, opportunities for myself down the line as well, and see how this would fit in. And I've been quite fortunate to continue my clinical side of things. So I still do clinics in primary and secondary care, and still do some education as well as work in general medicine, do some on calls as well. So it kind of still maintains my skills, which I'm key about, and I haven't changed that. So this is kind of me now. The official title I have is National Advisor for NHS Engagement at Sanofi UK. I work that 4 days a week. I do multiple clinics and primary care clinics, including MDT work. I have an education, I have a massive interest in education. I can't stop talking, a bit nerdy, you could argue. But again, Goggle Docs is what we set up, kind of named after Gogglebox, but Goggle Docs to kind of bring education to the masses. We're on YouTube and Twitter, so do have a look if it's interesting. It's probably a bit more technical stuff, but it's very much about diabetes, very focused. If you want any of that knowledge, that's the end. Really, I would say one question is, do you have any regrets? And no, I don't. You know, I'm a product of my experiences and where I am and all the opportunities I had and the path I took. So I have no regrets. But what I would say, and something to consider in the future, as much now, now and the future, work-life balance is key, and it takes time to get it right. I'm still learning about it, I would say. I have one more tip actually later, but which I'm still not learning. But yeah, I think this is probably a key thing. Figure out what you want in life in a way, and that takes time. It takes time, and then what works for you. But that's my tips. General advice: your career is what you make. Again, these are all inspirational things, so I do apologize. It's a bit cheesy. You know, your career is what you make of it. If you want to do it, you can do it, and if you want it, do it. Be aware of the future. Have an eye on that. You know, being a consultant and being a specialist is more than seeing patients. There's more you expect you can do, and you know, you're privileged to be able to do. So consider those options. Look at the other roles available. Identify those who can help you. I think it was mentioned earlier about what, you know, who to collaborate and speak to, registrars and consultants. And I would say Google or PubMed stalk them in a nice way. You know, just put their name, see, you know, if you're doing a project or want to work with someone, so you see what their kind of background is. And if they're someone who's, you know, publishes a lot or has done a lot in the national field, you know that what they're about, and that, you know, you can perhaps ask for that support. You know, so it's still a bit about who you know as well. So again, they offer those opportunities. And I would say learn to say no. This is the one I'm struggling with. I'm developing that, getting a bit better at it, but it takes time again. And again, it depends on your personality. And I'll leave you with this last bit. This is kind of, I have two kind of mottos in life. This is one of them. And this is actually from a Jason Bourne book. So opportunities present themselves, use them. And I think that's been probably the tagline for my career so far. And is probably where I am in a way. And so we'll leave you with that. Happy to answer any questions. And thank you again for your time.
Thank you so much, Dr. Pratana. So really an eye-opener. I often speak to a lot of medical students and colleagues. They think it's all about diabetes, all about clinics. So it's fantastic to see all the opportunities that are available in the field. So thank you so much to all of our speakers tonight. It's just been so great to hear your experiences. We'll move on to the Q&A section. So if you could use the chat function to ask questions, and I'm happy if you wanted to raise your hands and unmute yourself as well. I think we had a couple of questions. So Karen asked, FY2 at the moment, applying for IMT1. So obviously the IMT1 applications are a bit different to specialty training, but if you are interested in diabetes and endocrinology, you can definitely mention that during your IMT interview, and to show that you have thought about what you'd like to do beyond IMT training. And certainly for me, I knew that I wanted to do endocrinology since medical school, so already in my portfolio I'd started to collate some of that evidence, and you can definitely demonstrate that at the IMT interviews. And also a lot of the criteria, publications, presentations, prize, very similar for IMT and also the specialty training. So you can definitely start early. And I think my biggest advice is to collect all that evidence. I think we often do a lot of things, get involved in a whole range of teaching programs and things, but when it comes down to it, you may not have that certificate and things last minute. So keep that portfolio. I don't know if any of the other speakers wanted to add to that.
I think what you say is right. I remember looking and also telling some juniors as well that if you can, when you're looking at your IMT application or your what's called medical from your IMT, have a look at the registrar application just to see kind of what correlates, because then you can save yourself a lot of effort by ticking the boxes on both. I think that's the key thing. And when I applied for what was similar to IMT at the time, there were tick box exercises and there were specialty exercise things that I did. So the tick boxes were like present posters, or my posters were in I don't know if it's still there now, but again similar, but it was in a neuropsychology, one poster conference, a national neuropsychology conference, and the other one was in radiology. It wasn't in diabetes and endocrine, but I did enough of other things in diabetes and endocrine to kind of to validate why I wanted the specialty. But it doesn't, there's tick box things just to get the bare minimum, or there's stuff especially you can do both, but if not, don't worry, there's things that you can do.
Yeah, definitely. I think the next question was a little bit more specific on Dr. Quinn's research. I don't know if you wanted to add anything more with that.
No, there's really interesting papers I can send you, Hannah, about screening for type 1 and children. I all I would say is it's an interesting space, and I think the diabetes world tends to be on Twitter or X, whatever it is now. There's a big kind of diabetes community out there, and Partha Carr, a real ode to him as NHS England's diabetes lead, and a lot of those technology advancements I talked about is through Professor Partha Carr's leadership, so through NHS England. And so if you're really interested in diabetes, I would strongly encourage you to ears and eyes to the ground on social media. And that's where all of the updates that we're waiting for from NICE guidance on hybrid closed loops, it will be on there. So it's a good way to keep up to date.
Thank you so much. So if anyone has any more questions, then please, it's a really good opportunity to ask them. We've obviously got experts in the field on this call. So I think Julian just asked questions. So he's asking about evidence for posters. So he's asking if same evidence can be used for the IMT application for the higher specialty applications. As far as I'm aware, yes. So as long as it matches all the criteria, anything that you have done during foundation years, IMT and foundation years should count for both the IMT and higher specialty applications. And I think that's why it's really important to just look ahead. So if you are interested in endocrinology, just have a look at what things correlate between the IMT applications and the high specialty training, because you can often just do one thing that might tick both boxes. So as far as I'm aware, yes, all the evidence counts across both. I think if I could just ask the panel a final question, and obviously if there's anyone else that wants to ask questions, please do. What still inspires you in the field, and where do you see things going within the field of diabetes? And if I could start with Raj.
I was interested in diabetes endocrinology just because the broad scope of thing that you can be after becoming a consultant. You can go into research, you can go into, there's so many branches of this specialty, and it's not just one organ, it's the entire body, it's the whole metabolism. So like if you were to choose any other specialty, you're just confined to one organ or a couple of organs, but it's not like this. It's the entire body, and it's quite fascinating. It's quite interesting how all of this is interconnected, and and loads of options. I mean, I'm still exploring every new rotation. I meet new people, and so we can do this. Oh, so this is also something that we can try. So yeah, it's quite intriguing, thought-provoking, and that's one of the reasons why I love this specialty.
Thank you so much, Dr. Quinn.
Yeah, I completely agree, Raj. And yeah, you'll find your subspecialty interest within endocrinology and diabetes. And as you go through your specialty training, you will dual train in endo and diabetes. And then it really depends, if you have more an endocrine focus in a tertiary endocrine center, that's possible. If you want to work in more like a district general and want to work in both specialties, that's possible. So I think just like Dr. Patana said, the choice is yours. You make your career as you go along, and whatever interests you, just follow your passion, I would say.
Great, thank you. We've got a question come through, so thank you, Andy. He's just wondering a bit more about how the mixture of the academic and clinical pathway works, and he's spoken to some academic fellows who appear quite busy. I think, Dr. Quinn, I'll come to you first, and then maybe I can add a bit to that.
Oh yeah, absolutely, Angelica. Yeah, so with the academic clinical fellowship, so you're technically supernumerary in that role. As an IMT, it's just for all intents and purposes IMT, and it's a lot of clinical work to do. But I think the portfolio is very achievable, even though you have less clinical time. It's perfectly achievable. Obviously, I haven't done a lectureship yet, so I've not been in that position. But again, you are supernumerary, and that is because your research time needs to be protected, so that you're doing impactful research for your patients. So I think, yes, an academic path is not an easy one, and it's not a 9 to 5, but if it's something you enjoy, it doesn't really feel like work at the end of the day. So I think it's perfectly manageable. I don't know what you would say, Angelica.
No, I agree. So I've just done 1 year of it, so I'm now in IMT2 ACF, second year of the ACF. The thing to consider is when you're applying for these pathways, they're all structured a little bit differently. So some of my colleagues will get 1 day a week to do the research and then 4 days clinical, whereas I have a 3-month block to get that done in. And a lot of people prefer different styles. I think for me, it's quite nice to have both, and certainly clinical work can get really hectic, and it's always nice to have the academic side. And actually, a lot of the work I've done has been quality improvement projects and to actually make a difference on the wards. And then when you're doing your clinical time, actually see that difference come into play. So I find that is really motivational. I haven't struggled personally with getting all the parts of the portfolio done. I think if you're proactive and, you know, during your clinical rotations, if you try and get the sign-offs that are necessary, then it's definitely achievable. And I think a lot of my academic work is across the year, actually. So even if I do get the 3 months, I feel that I'm still feeding into various pieces of work. So it keeps you busy, but it's exciting, it's fun, and I think I really enjoy the balance. I don't think I could do 100% clinical, so it's really nice to have that balance. Any other questions? So whilst we wait for any more questions to feed in, I'd just like to tell everyone that the link to this webinar will be available. So if there's any parts that you missed, you'll be able to catch up on that. It'll be uploaded to the Society's YouTube channel. You will be able to obtain a certificate of attendance, and we'll send you out an email. There'll be a feedback questionnaire. So if you could just fill that in, then we will send you the certificates. And again, this is all part of your commitment to specialty. So even attending today's talks, I hope it's given you things to think about and to go away and collate your portfolios. And I'm happy to answer any questions via email if ever anybody wanted to get in touch. So I'll post them on the chat. So if there's no...
We do have hands, Angelica, how many people we've convinced to pursue diabetes.
Oh yeah, that'd be quite fun. Yeah, okay. Oh, I'm scared now. Maybe we put them up. Yeah, if you could raise your hands if we've convinced you. Quite a few. I'm happy. Nearly everybody. That'd be really good. Great. Thank you so much. And again, a massive thank you to our speakers as well.